Welcome to the Orthopedic Indications channel, where we discuss medical education for medical sales consultants and reps.
Hi, my name is Nick Strasser, and this is Indications. And on this channel, we really focus on talking through some of our indications for surgery, and particularly as it relates to foot and ankle surgery, particularly as it relates to those in medical sales reps, but also anyone that's interested in foot and ankle care and deals with it on a routine basis. I'm focusing this episode on ankle instability and specifically talking through some of the workup and key factors that we're looking at when these patients present to clinic, and then start with a little bit of a case example. So I use this case because I think it's an interesting discussion when you get into ankle instability, because there's multiple ways this can present. Broadly speaking, we talk about things such as functional ankle instability or mechanical ankle instability. Mechanical meaning it's just structurally too stretched out or too ligamentously loose, as opposed to functional, where there's something else going on that's making it feel painful or weak, such as like peroneal tendon pathology. And I'll just take a step back and talk about, or just mention that, when I talk about ankle instability, what I'm really talking about is like an inversion ankle injury. Certainly, I'm going to do some discussion on high ankle sprains in a later video, but this is on this one, I'm going to focus mostly on the more standard inversion sprains, low ankle, whatever you want to call it, the more common ankle sprain, and just trying to keep you out of any sort of sticking points and tricky things that can come up with some of the management and presentation of these patients. So this is a mid 20-year-old female presenting with right-sided ankle pain, and she's a former Division I athlete. She's now into CrossFit and training for some of these obstacle endurance races, and so she rolls her ankle after she steps in a hole on the right side, and she presents after 4 to 5 months of physical therapy. She's been working on all the things. She's very objective in terms of how much she could squat before and how much she could squat after the injury. So it felt like she just couldn't trust the ankle, and points to that kind of anterolateral aspect, like most of these patients do, in that general vicinity. And feels a little loose, a little bit unstable, but kind of gives us, the presentation isn't as clear as you might expect it to be when you see it when you see her in clinic, because she's describing some pain, and I wouldn't expect the squat to be overly limiting when it comes to being able to trust your ankle. But this is her ankle X-ray, and the lateral X-ray, which shows a little bit of chronic changes. Her axial view certainly shows a disruption of the ATFL, and if you look at her coronal images, what you see is a little bit of disruption of the CFL, a little bit of fluid around the peroneals, a little bit of fluid in the joint itself, but nothing too concerning going on in terms of the bony structures. And but she had failed non-operative treatment. We talked about doing an arthroscope and a collateral ligament, which is kind of my standard approach, is to add the arthroscope, because we want to look at the articular cartilage, because even when it doesn't look that bad on the MRI, occasionally we'll stumble across some pathology. And lo and behold, when we get in on her arthroscope, we see there's a lot of anterior lateral synovitis, and there's a disruption of the articular cartilage on the lateral side, right directly at the area that she hurt. So and this really was not visible on the MRI, or at least when I looked at the MRI, kind of in hindsight, I could kind of see it, but certainly wasn't read out by radiology. And I thought maybe one cut that you could kind of see it. So it was a very subtle finding, even in retrospect. So it lends itself to the discussion of how we need to look at these patients. You think about the way they present, and we recognize patterns on some of these certain diagnoses. And so we certainly want to do the same thing when it comes to an ankle sprain. So we want to be looking for those things. So we want to hear about their history. Did they roll it? How did they roll it? Could they walk or weight bear after the injury? Did it swell? Did they feel a pop? Sometimes defining sprain it takes a little bit of work too, meaning that occasionally I've had a patient who said, I sprained my ankle, and you say, okay, tell me what happened. And they say, well, I didn't have an injury, I just started hurting, so I figured I must have sprained it. And so they don't give a really defined mechanism of injury. And so that's a little bit of a red flag that there's maybe something else going on that I need to be thinking about. Is it chronic tendinopathy? Is it some other condition that's going on as opposed to like a true ankle sprain? So history is really important. We want to know if they have pain or if instability or if is it both. Sometimes instability can cause pain. Sometimes pain can cause instability. So we're kind of working through that. I'd make a big portion of my diagnosis based off of the exam. So where are they having pain? And understanding the surgical anatomy is really a valuable tool when you see these patients in clinic, because then you know if they're hurting on the medial side, for example, they probably don't have an ATFL injury. Or even just anterior process fractures of the calcaneus. Sorting those things out can be really helpful. And then imaging, so working through the x-rays, working through the MRI, and then patient expectations, always making sure you understand what they're trying to get back to, what their limitations currently are. The normal anatomy consists, we're going to focus the most on the ATFL and the CFL. So ATFL controls our anterior translation, whereas the CFL controls our lateral tilt across both the tibiotalar and the subtalar joint. Interestingly, if you look at MRI of injured ankles, ATFL is most frequently injured in isolation. So we want to think about that one. That's a great test question. And only 1 out of 5 actually have a combined injury. The ATFL is this flat band. It runs off just above the lateral process of the talus, attaches to the fibula, and then there's a small, wispier, smaller band called the calcaneofibular ligament. That actually runs a little bit more posterior than you might think. So it runs underneath the peroneal tendons, as you can see on the image on the right. The ATFL is a flat band. It's got a bifurcation in the middle, so kind of 2 bundles, so to speak. And there's an artery that pierces there, an arteriole that pierces that area. And so there's sometimes you'll notice these like first-time ankle sprainers have a really bad, swollen, a lot of bruising about the ankle. And I think that there's some injury that occurs to that arteriole as well. So we want to be aware of that. The exam, I mentioned this already, but we want to make sure we know where they're hurt, where their maximal pain is. This is a little bit easier after things get settled down a little bit. We want to check their tendon function, so the anterior tib, the Achilles, the peroneals, the posterior tib. We want to make sure all that stuff's working. We look at alignment. We look at the ligamentous exam. I think most people are familiar with this, but this is a basic ligamentous exam for an anterior drawer and a lateral tilt. So our anterior drawer, we're stabilizing the tibia, get my hand behind the calcaneus, and then trying to sublux that talus forward. Bending the knee is oftentimes quite helpful. And then if you do a lateral tilt, you get your thumb just off the corner of that lateral process, and you can actually feel that opening up a little bit right there, that little dimple that you're seeing. The lighting's not great in that video, but you can see that there's a little dimple. If you can just get them to relax, a lot of times that really helps open up the exam, and then really check the other side as well. Sometimes you'd be surprised that even though they come in with complaining on one side, both sides actually have some evidence of instability. And we don't operate necessarily on instability alone. It has to be causing dysfunction, limiting their ankle mobility. And I didn't mention this before, but sometimes asking how many times a day or a week or a month do you sprain your ankle? What kind of mechanisms lead to the ankle sprain, rolling the ankle? It's worth mentioning subtle cavus feet. That's where we see a little bit of hindfoot varus or plantar flex first ray. I'm not going to come on here and be a proponent of doing osteotomies on everybody that has subtle cavus foot, but it is important to discuss and at least be aware of, particularly if you think about orthotic management after such an injury. And we know that varus is basically where the joint of interest is medial to the midline. So we've got the midline marked out here. We got the heel into a little bit of varus, and that's putting a lot of stretch and strain on, in this case, the ATFL and the CFL. But don't forget about peroneal tendon pathology and fifth metatarsal fractures in particular associated with this particular condition. So it's worth mentioning if it's a revision situation, but it is also worth mentioning from a perspective of orthotic management as well. And then you have to think about all the other causes of ankle pain after an ankle sprain. If you don't look for these, you'll miss them. Some of these are really subtle. You have to really you have to dig into the x-ray a little bit. You have to take an extra second to look at these different spots because sometimes they don't necessarily just pop out readily. So anterior process fractures of the calcaneus, you got to look at that lateral view. You got to study the lateral view. Oftentimes it's only an ankle x-ray, and so looking at the fifth metatarsal because it kind of sneaks off to the side is extremely important. Lateral process fractures of the talus, sometimes those are hard to see depending on the view that you get. Maybe it's a little bit oblique. Maybe it's on the lateral view. You can kind of see it sneaking in that area. And if I suspect that, then oftentimes I'm going to get a CT scan to further define it. Don't forget about high fibula fractures. This should show up on an x-ray, but if it's a Mason-Yu, where it's up the fibular neck proximally, you may not see that on an x-ray. You may not see any pathology in the ankle if it's a non-stress situation. So looking at and feeling those areas on the exam is important. Achilles tendon ruptures happens all the time where they get told they have an ankle sprain, and if you don't examine it, you'll miss it. And sometimes they present with a rather subtle presentation. So looking for the Achilles tendon. Peroneal tendon pathology occurs very frequently with a similar mechanism where they roll the ankle, and so being aware of possible split tears of the peroneal tendons or even subluxation or dislocation, taking care to look at that AP x-ray or mortise x-ray and looking for a flex sign off the fibula can be a really good way to kind of to dig in to figure out if that's the case or not. And then syndesmotic injury, I'll talk about this more detail a little bit later, but syndesmotic injury can be missed and is important to know, particularly in the athlete, because you want to be able to give them an adequate or an accurate diagnosis, and this has a little bit of longer recovery as compared to a typical ankle sprain, so identifying this is very important as well. And then osteochondral lesions, so looking at the lateral dome of the talus, if you suspect it, getting advanced imaging to look at the articular cartilage, particularly in the athlete. We have a low threshold to get advanced imaging. Don't forget the midfoot, especially if you see this. If you see plantar bruising, you got to be thinking about the possibility of a midfoot injury, and then additional imaging needs to be obtained. And then finally, the anterior tib tendon. Make sure you feel that they can function and fire the anterior tibial tendon, particularly in that little older patient, maybe 50, 60-year-old patient. And this often, what I notice about this is it oftentimes presents in a rather subtle manner. It's oftentimes not a dramatic tear such as an Achilles tendon. Most of the time these are attritional, so there's been some disease pre-existing, but they may come in with an abnormality in gait or something like that. So you have to really be thinking about that one, because they can use EHL to overpower, to overcome some of the deficits of it, and you kind of get tricked in these cases. I get 3-view ankle x-rays on pretty much all of these. Very reasonable to get a foot x-ray, particularly if you suspect additional pathology. Ultrasound, fluoro, MRI, CT scan are all on the table depending on what's going on. We don't jump to those immediately, but if there is something that I suspect that there's a different diagnosis, for example, lateral process fracture of the talus or an osteochondral lesion, then I'm going to get additional imaging in those cases. Just a word on the MRI imaging, and there's like so much pathology that I just talked about. I'm not going to go into looking at all of those on the imaging, but since we're talking about lateral ankle sprains, I'm going to just mention ATFL and CFL injuries and how to look at them on a MRI. So if you remember, ATFL is associated with the axial, and you look at the images A and B at the top. You can see as you go through the slices that we get down to more of that distal fibula, and at that level it turns into what looks a little bit like a kidney bean or a kidney basin, and that's the level you want to be at to look at the ATFL as it goes from the fibula and attaches to the talus. So you look at that level, and then you can define, hey, that's where the ATFL should sit. So if you look at image A and image B, you can see it's marked out with an arrow in this particular diagram. And if we go to some practice slides here, where we are looking at a patient that has a little bit of peroneal tendon pathology, but you can see the disruption of the ATFL there. And I'll see if I can go back and show you this area right here you can see that area of disruption off the fibula, where the fibula becomes a kidney bean. So a couple other case examples. You can see a normal one here on the top on the left, and then the middle is more of a chronic ATFL disruption. So again, getting to the level of the kidney bean. And then as you go a little bit farther down, you can see the disruption of the more of an acute disruption in that situation. And then the CFL, I'll go to the coronal, and I'll kind of scroll back and forth in the underneath the perineal tendons and look for that attachment onto the calcaneus. And you can see this triangle marking out a normal looking CFL, but that's how you would look at it. That one's a little bit harder to fully define, I think, and it does take a little bit of scrolling back and forth to kind of get a full picture on that, because it's a little bit of an oblique angle, but that's a pretty good way to look for that. Again, remember, that's only injured in about 1 out of 5 of like acute ankle sprains, but certainly can see it. What about stress x-rays? Stress x-rays are certainly reasonable to get. They're not as reproducible as we would like. If you have the same person doing it, and it's pretty reliable in terms of being able to look at the x-ray on the AP view or mortise view and discern whether they have tibiotalar tilt, as long as you can do it in a reproducible manner. It's a little bit more difficult on the lateral x-ray. You're measuring in millimeters of translation, so you have to have a normal, and then you have to kind of mark that out, and then you have to do an anterior drawer under fluoro or under x-ray and see how much translation. But it's a little bit of a question of how much force do you exhibit, how much do you pull, how much are they relaxed, all those kinds of things. So it's not the most reliable test. I will certainly use it intermittently, particularly in like a revision situation, or if they're really globally unstable and I'm questioning if I need to use some sort of augmentation. That might help me in that decision making for these really severe cases. So I think that's a great start to ankle instability. We talked about some of the key factors with the exam. I mentioned things that you want to look for on their imaging or on their exam to not miss other injuries that can be that can mimic things. We talked about how to look at like an MRI and look at the ATFL and CFL, and then we talked a little bit about some stress x-rays and their role. And I'll talk more about some of the surgical interventions in our next video, and then we'll also eventually get to medial, talk about some of the deltoid related injuries, as well as the syndesmosis injuries. All right, take care.